So good afternoon, everybody. So today we are going to see about the anatomical features, histological and embryological aspects of the other endocrine organs, which is the adrenal gland, the parathyroid gland, and the pancreas. Okay. Okay. So let's see about the adrenal gland. Okay, the adrenal gland, you know that it's also referred to as the suprarenal gland. Okay, because it is located above the kidneys, so it's called as suprarenal gland, and it is a retroperitoneal structure. Okay, it's a retroperitoneal structure because you know that the kidneys are also retroperitoneum. So this adrenal gland, which is situated on the top of the kidneys, they are also retroperitoneal structures located on the upper wall of the kidneys, and it is surrounded by the renal fascia. Okay, it is surrounded by the renal fascia, but it is separated from the kidney by the perirenal fat. Okay, so there will be a small layer of fat which separates the adrenal gland from the suprarenal gland. Okay, so here you can see the adrenal gland. Okay, so this is the renal fascia. Okay, the renal fascia. Okay, and you can see that it is enclosing the kidney, and this is the suprarenal gland or the adrenal gland. The right suprarenal gland, if you see, it is pyramidal in shape, whereas the left one is half crescent or lunate shaped. Okay, so it is crescent shaped one, the left sided adrenal gland, whereas the right sided is pyramidal in structure. Okay, and the structure which is located anterior to the right suprarenal gland, so you know that the right hypochondrium, mostly it was occupied by the liver, so the anterior relation would be the liver, and posteriorly, since it's a retroperitoneal structure, the posterior relation would be diaphragm. The left suprarenal gland is crescent shaped, as I said before. And what are the structures which are related anterior to it? So immediately anterior to the left suprarenal gland would be the pancreas. Okay, then the lesser sac and the stomach. Okay, that is from posterior to anterior. Okay, so the anterior structures which are located anterior to the left suprarenal gland, and posteriorly it's just the same, the diaphragm. The blood supply of the adrenal gland. Okay, it receives its blood supply by three arteries. Okay, superior suprarenal artery, middle suprarenal artery, and inferior suprarenal artery. Okay, so that's quite easy, but usually they will ask where do they originate from. The superior suprarenal artery or the superior adrenal artery, they arise from the inferior phrenic artery. Okay, the artery which goes and supplies the inferior aspect of the diaphragm. Okay, so from this there is a branch which is the superior suprarenal artery. The middle suprarenal artery is a direct branch from the aorta, and whereas the inferior suprarenal artery is a branch from the respective renal arteries. Okay, the right-sided inferior suprarenal is from the right-sided renal artery, and the left-sided inferior suprarenal is from left-sided renal artery. So that's about the arterial supply. Coming to the venous drainage, the right-sided, there is only one veins. Okay, so there is a right suprarenal vein and a left suprarenal vein. The right suprarenal vein drains directly into the inferior vena cava, whereas the left suprarenal vein goes into the left renal vein. Okay, so the right goes into the inferior vena cava, whereas the left suprarenal vein goes into the left-sided renal vein. So here in this picture, you are able to see all the blood supply. So here you can see superior suprarenal artery. So these are the superior suprarenal arteries, middle suprarenal arteries, and inferior suprarenal artery. Okay, superior, middle, and inferior suprarenal artery. Sorry, this is superior suprarenal artery, middle suprarenal artery, and inferior suprarenal artery. Superior is from inferior phrenic artery, middle is a direct branch from the aorta, whereas the inferior one is a branch from the renal artery. Okay, it's a branch from the respective renal artery. In this picture, you can see the venous drainage. The right sided suprarenal vein, it actually drains into the inferior vena cava or the junctions between the right renal vein and the inferior vena cava. Okay, but in this picture, it's shown as if it's draining into the right renal vein. Okay, but usually in most of the cases, the right suprarenal vein goes into the inferior vena cava, whereas the left suprarenal vein, it goes into the left-sided renal vein. Okay, so it goes into the left-sided renal vein. So right into the inferior vena cava, and the left inferior suprarenal vein would go into the left-sided renal vein. All right. So this is about the gross features of the adrenal gland. Any doubts until now? If you have any doubts, please unmute your mic and let me know. All right. So let's go to the next part, the lymphatic drainage of the suprarenal gland. The right and left suprarenal glands, they go and drain into the lateral aortic group of lymph nodes. Okay, the right into the right lateral and left into the left lateral aortic, that is the nodes which are located on either side of the aorta. Okay, and the nerve supply is by the preganglionic nerves from the splanchnic nerve. Okay, from the splanchnic nerves, so that will be the nerve supply, okay, which goes and supplies the adrenal medulla. The preganglionic nerve from the splanchnic nerve, they go and supply the adrenal medulla. Now let's look into the histological aspects. The histologically, the adrenal gland can be divided into two parts, an outer cortex and an inner medulla. Okay, so outer cortex and an inner medulla, both right and left. Okay, so they have an outer cortex and an inner medulla. The adrenal medulla, it's composed of, that is the medulla which is near the center. If you see the center of the adrenal gland, you will be able to see chromaffin cells. Okay, chromaffin cells and parasympathetic ganglion cells. Okay, parasympathetic ganglion cells. So these are the two types of cells which are present in the adrenal medulla, chromaffin cells and parasympathetic ganglion cells. Okay, so what are the functions of these chromaffin cells and why it is named so? It is named chromaffin cells because they get stained with chromium salt. Okay, so when you add a chromium salt and then look under the microscope, okay, so they will be giving a different color. So that's why these are called as chromaffin cells. Okay, they are considered as a modified sympathetic postganglionic neurons. Okay, so modified, it's a sympathetic postganglionic neuron. So you know that there is a preganglionic and postganglionic. So the chromaffin cells are usually considered as a postganglionic neurons. They are controlled by preganglionic sympathetic neurons. Okay, so this adrenal medulla, they are controlled by preganglionic sympathetic response. So if there is some fear, okay, or some danger, you know that the sympathetic nervous system acts. So what happens? The sensation from the imminent danger, so is being sensed, okay, and then it passes signals through the preganglionic, okay, to the preganglionic sympathetic neurons to the adrenal gland, okay, where they will be secreting the hormones which is epinephrine, okay, and norepinephrine, okay, epinephrine and norepinephrine. Okay, so these are the hormones which are responsible for flight, fright, and fight. Okay, so that's about the chromaffin cells. Okay, because it stains with chromium salts, considered as a modified sympathetic postganglionic neurons. The other cells which is present in the adrenal medulla, it is parasympathetic ganglion cells. Okay, parasympathetic ganglion cells. Okay, so apart from sympathetic postganglionic neurons, there are some parasympathetic ganglionic cells as well. Okay, so this is how the chromatin cells will look under the chromium salt. Okay, so this is how it looks. Okay, so this is the histological picture of suprarenal gland. Now that's about the medulla. Now what about the cortex, the outer cortex? The outer cortex of the medulla is divided into three parts. Okay, from outside to inside. Okay, zona glomerulosa, zona fasciculata, and zona reticularis. Okay, zona glomerulosa, zona fasciculata, and zona reticularis. Okay, the zona glomerulosa. Okay, so they are formed by round or arched cluster of pyramidal cells. Okay, so they are formed from pyramidal cells and they secrete mineralocorticoid. Okay, mineralocorticoid, not glucocorticoid. Mineralocorticoids are the ones which control the electrolyte in our body. Okay, so they control the mineralocorticoids. Okay, and under the cover of renin. Okay, another hormone which is called as renin. It acts along with them and then acts in the zona glomerulosa, okay, to secrete mineralocorticoid. Now coming to the zona fasciculata. The zona fasciculata, it is formed, why it's called fascicles? Because it is perpendicular. Okay, they are formed by parallel cords of polyhedral cells. Okay, so formed by parallel cords of polyhedral cells. The cells are also called spongiocytes. Okay, the cells are also called spongiocytes and they secrete glucocorticoids. Okay, okay, so fasciculata will be secreting glucocorticoids and glomerulosa will be secreting mineralocorticoids. The remaining part, which is the reticularis part, it is composed of anastomosing cords. Okay, because it is anastomosing, that's why it's called as a crease. So the zona reticularis is composed of anastomosing cords, and they secrete androgens as well as glucocorticoids. Okay, so they secrete both androgens as well as glucocorticoids. So these are the three different zones, okay, so which can be seen histologically in the adrenal gland. So this is a histological picture. So here you can see the outermost covering, which is the capsule. Next is glomerulosa, fasciculata, reticularis. Okay, you can see it is more crowded here in the glomerulosa. The next one is the fasciculata layer. So where the cells, they are arranged in columns from top to bottom. Okay, so that's regarding the zona fasciculata. Coming to the deeper zones, so there will be presence of chromatin cells and zona reticularis. Okay, so there is a formation of zona reticularis. What is reticularis? Because the cells are arranged in a reticular fashion. Okay, so they are arranged in a reticular fashion. Okay, reticular means like crisscross. Okay, so that's all regarding the histology of the adrenal gland. So once again, it has got both the adrenal cortex and medulla. The adrenal medulla, it is controlled by the preganglionic sympathetic neurons and secrete epinephrine and norepinephrine. Okay, epinephrine and norepinephrine. The lymphatic drainage and the nerve supply, whereas the blood supply of the adrenal gland. This we have finished, right? Sorry, I'm going front. The adrenal cortex is derived into three parts, which is glomerulosa, fasciculata, and reticularis. Okay, so the glomerulosa, they secrete mineralocorticoid, fasciculata, they secrete glucocorticoids. The zona reticularis, they help in they help into secrete androgens and glucocorticoids. Okay, so they are also helpful in composed of they help in secretion of the androgens and the glucocorticoids. So that's regarding the histological aspects. Coming to the developmental aspects, the adrenal glands, as we know that it is located in the posterior abdominal wall, they develop from two tissues. Okay, so they develop from actually two tissues. Okay, so the immediate mesoderm, okay, the mesoderm which gets attached, so they form the adrenal cortex, whereas the neural crest cells, okay, you know this diagram which must have been taught to you in your foundation module. So you know that the neural crest cells are formed. These neural crest cells, they give rise to the formation of adrenal medulla. Okay, so they give the formation of the adrenal medulla. So the adrenal glands are located in the posterior abdominal wall, situated above the kidneys, and they are developed from intermediate mesoderm and the neural crest cells. Okay, any doubts? Do you have any doubts? Okay, so basically, the adrenal gland they develop from both mesoderm as well as from neural crest cells. Okay, the cortex develop from mesoderm, whereas the inner part, okay, the neural crest cells. They form what is called as the adrenal medulla. Some of the clinical aspects. Can you know? Can you tell me what finding is this? I think in histology it's all sorry in physiology it's already over. Any idea what is it? Sorry. So this is Cushing syndrome. Okay, so you can see the abdominal striae. Okay, so the abdominal striae. Okay, so this is because of excess secretion of corticosteroids. Okay, the excess secretion of corticosteroids. So they lead on to the this condition which is called as Cushing's syndrome. Okay, so these are some of the features of the Cushing syndrome. Okay, so I'm not going into the details of these ones, so which will be covered in the physiology and pathology. Okay, pathophysiology. So they are likely to have emotional disturbances, moon phase. The bones will be thin, which is called as osteoporosis. Okay, hypertension will be there. The buffalo hump, there will be a pad of fat just below the neck, which is called as the buffalo hump. Okay, there will be obesity, abdominal striae, the skin will be thin, okay, amenorrhea, muscle weakness, purpura, and skin ulcers. So these are some of the features, okay, which can be seen in Cushing's syndrome. Okay, the other clinical conditions are pheochromocytoma. So the pheochromocytoma is because of a tumor which is present in the adrenal medulla. So adrenal medulla, you know that it secretes epinephrine and norepinephrine. So here the patient, they will be in pheochromocytoma, they will be always anxious. Okay, so they will be sweating profusely and has an anxious look most of the time. Okay, the Addison's disease, this is just opposite to that of Cushing. So here this is decreased secretion of corticosteroids, okay, as well as some of the electrolytes. So there will be some electrolyte imbalance which can be seen in Addison's disease. So usually they will be having albinism. Albinism means they will have less color, albin, you know, white. Okay, so they look white, and they are likely to have electrolyte imbalance and hypotension. Okay, hypotension. The blood pressure will be very low. Okay, so these are some of the clinical conditions associated with adrenal gland. Any doubts? Okay, I'm not going into the details of this. It will be covered in pathology as well as in physiology. Okay, so now let's go to the next topic. So imagine that you are the physician and a 58 or 54-year-old female, okay, who has undergone post-thyroidectomy. Okay, so that is the thyroid surgery is already done. Okay, and she is in her post-operative room. Okay, so the surgery went off successfully. Okay, and the patient is now in the post-operative room. The nurse calls you, okay, and saying that the patient looks a little bit abnormal. Okay, so the patient is still in the post-operative phase. Okay, she is not fully recovered. Okay, but then she reports something abnormal, and it looks like this. Okay, it looks like this. Okay, so what is this? Anybody? Can you just unmute your mic and let me know? What is this condition called as? This condition is called as tetany. Yes, it's called as tetany. Okay, and what is this specific sign? Okay, you can see there is flexion of the metacarpophalangeal joints. Okay, flexion of the metacarpophalangeal joints and extension of the interphalangeal joints. Okay, flexion of the metacarpophalangeal joints and extension of the interphalangeal joint. Okay, so this is called as main d'accoucheur. Okay, main d'accoucheur. So which is a French name. Main means hand. Accoucheur means midwife. Okay, midwife. Okay, in English it's called as obstetrician's hand. Okay, obstetrician. You know, obstetricians, those are the doctors who help in delivering the babies. Okay, so whenever they during the delivery, okay, so during parturition, okay, so they hold the baby when the baby is coming out from the mother, they hold the baby, okay, by keeping the hand like this. Okay, so they keep the hand like the flexion of the metacarpophalangeal joint and extension of the interphalangeal joint to receive the baby. Okay, so that's why this is called as main d'accoucheur. Okay, so similar to that of the obstetrician's hand. Okay, so why did this come? Why did tetany come in a person with post-thyroidectomy? How did it come? Is it because of the thyroid? It is because of the accidental removal of parathyroid gland along with the thyroid gland. Okay, so when along with the removal of the thyroid gland, okay, you need to prevent as much as possible to prevent the removal of the parathyroid gland. Okay, so what is the hormone which is secreted? Parathormone, okay, and also calcitonin. Okay, it also secretes parathormone and calcitonin, which helps in calcium metabolism. Okay, in the regulation of the calcium levels in the body. Okay, so these parathyroid glands, they are small, oval in shape, approximately 6 millimeters. So you can see like how small and tiny they are. Okay, they are approximately 6 millimeter and 4 in number. Okay, two superior parathyroid and two inferior parathyroid glands. Okay, and they are located along the posterior border of the thyroid. Okay, so they are located on the posterior border of the thyroid. Okay, and they lie within the thyroid capsule. Okay, so they lie within the thyroid capsule. You know that the thyroid has got a capsule. So the parathyroid also is closely related to the thyroid, and that's why it's called as parathyroid, and they lie within the same capsule. Now let's see each one of them, the superior parathyroid and the inferior parathyroid. The superior parathyroid is usually more constant in position. They are located in the posterior border of the thyroid. Okay, so here it is represented because this is a drawing. So here it is represented. Okay, but in reality it is quite difficult. Imagine 6 millimeter structure in a thyroid gland, that might be very difficult to identify. Okay, the superior parathyroid is more constant in position and approximately in the mid posterior border of the thyroid gland. Okay, so in the approximately in the middle of the posterior border of the thyroid gland, the superior parathyroid gland is located. Now coming to the inferior parathyroid gland. The inferior parathyroid gland, it is not in constant position. Okay, unlike the superior parathyroid. Okay, the position of the inferior parathyroid varies. Okay, sometimes it is within the thyroid fascia, sometimes it is located inside the thyroid, outside the fascia, sometimes even outside the thyroid as well. Okay, sometimes close to the inferior thyroid veins, or sometimes very close to the thymus, that is the superior mediastinum. Okay, so the inferior parathyroid gland is not constant position. Okay, it's not in constant position. Okay, all right. Now coming to the blood supply. The blood supply is same as that of arteries. Okay, so arteries which supply the thyroid gland. So the arterial blood supply by the will be by the superior and inferior thyroid arteries, whereas the venous drainage is by the superior, middle, and inferior thyroid veins. Okay, so I'm not going to go into the details of where the superior thyroid artery arises from, where the inferior thyroid artery arises from. Okay, superior thyroid vein drains into where, middle, okay, and inferior. So those things it must have been already covered in in the previous lecture on thyroid gland. Okay, so superior thyroid, anyone can you tell me where is it arise from? It arises from external carotid artery. Okay, the superior thyroid artery arises from external carotid artery, whereas the inferior thyroid artery, they arise from the thyrocervical trunk. Okay, and the superior and middle thyroid veins, they go into the respective internal jugular veins, whereas the inferior thyroid veins, they join together and then they finally drain into the left brachiocephalic vein. Okay, so they drain into the left brachiocephalic vein. Okay, so that's regarding the venous drainage. The lymphatic drainage is the deep cervical and the paratracheal lymph nodes. Okay, and the nerve supply is by the cervical sympathetic ganglia. It's by the cervical sympathetic ganglia. All right, so that's it regarding the parathyroid glands. So the parathyroid glands, there are two superior parathyroid and two inferior. Superior is more constant in position, and whereas the inferior keeps on varying in its location. Okay, and the blood supply is similar to that of the thyroid. The lymphatic drainage is into the paratracheal and the deep cervical lymph nodes. The nerve supply is by the cervical sympathetic ganglia. Any doubts until now? All right, coming to the next one, the histological features. The histological features, the parathyroid gland has got two different cell types. One is the chief cells. Okay, the chief cells, so they secrete parathyroid hormone, and the other one is oxyphil cells. Okay, the oxyphil cells. Okay, so they are polygonal and Doppler stained, but their function is still not yet known. Okay, the oxyphil cells, the function is still not very clear. Okay, so the chief cells and the oxyphil cells. Okay, so here you can see the oxyphil cells and these small tiny ones, these are the chief cells. Okay, the chief cells. Okay, okay, so now these are some of the questions for which it will be nice if you know the answers and your MCQs can come from this. Okay, so how to differentiate a thyroid swelling clinically from sebaceous gland, so sebaceous cyst, thyroglossal cyst, and a lymph node? Any idea? The thyroid gland and how do you differentiate a lymph node? Let's take the lymph node. The lymph node, it is usually present deep to deep fascia. Okay, so you make the deep fascia contract, ask the person to flex the neck against resistance, and then palpate the lymph node. Okay, so you know that the deep fascia is contracted, and if the swelling becomes less prominent, it means that it is deep to deep fascia. Then you need to look into the consistency as well as the location, and then confirm that this is a lymph node. The next one is the sebaceous cyst. Sebaceous cyst is also the same, okay, but it is the superficial fascia. You know, the sebaceous glands, they are located superficially. Okay, so even when you do now, if you ask the person to do the contraction of the deep fascia of the neck, that is by bending the neck against resistance, okay, the sebaceous cyst will become, it's superficial. Okay, so it remains the same. Okay, so there will be no changes. The next one is the thyroglossal cyst. The thyroglossal cyst, this is a tiny gland. Okay, so I will be telling you the importance of it when we discuss about the embryology. Thyroglossal cyst, how to differentiate it from the thyroid. Both the thyroid as well as the parathyroids, they both are enclosed in the thyroid fascia, okay, which is the deep fascia of the neck. So what happens when you ask the person to swallow? When you ask the person to swallow, then the deep fascia of the neck will move and the swelling of the thyroid gland also moves. Okay, so that's why we, how will we find that this is a thyroid gland or a thyroglossal cyst? Now, how to exclusively find out which is the thyroglossal cyst? Thyroglossal cyst, okay, the thyroglossal cyst, okay, so they, when I ask the person to protrude the tongue, okay, so ask him to protrude the tongue, the thyroglossal cyst also moves up. Okay, the thyroglossal cyst also moves up when the patient protrudes the tongue. Okay, so that's the thyroglossal cyst. Okay, whereas the thyroid gland does not protrude. Okay, so does not move when there is a protrusion of the tongue. Okay, so this is another one. So you can find out like this is basically the relations of the thyroid gland. Okay, so since we are discussing about the parathyroid, I'm not going into the details of this one. The last is what precaution. This also you know that the ligating the thyroid arteries. So you know that the external laryngeal nerve and the recurrent laryngeal nerve. So they need to be secured before ligating the thyroid arteries. Okay, now the Trossius sign, Mandakuja sign, Schwastek sign. So what are these signs? All three are signs of hypocalcemia. Okay, so there are signs of hypocalcemia. So which is the result of low parathyroid hormone. Okay, so there is low levels of parathyroid hormone, which leads on to these signs. So what is this Trossius sign? So in this, the Trossius sign, you ask the person to sit and raise the blood pressure. Try the BP cuff around his arm and increase a little above the systolic pressure. Okay, and leave the hand like that. Okay, for 5 minutes. Okay, so it is slightly painful because you know that the blood circulation is affected. So there will be a tingling sensation, which can be painful for some persons. Okay, and what happens once again after a certain time, the leg, the hands, they will be going into Mandya Akusha time. Okay, you know what is Mandya Akusha? Flexion at the metacarpophalangeal and extension at the interphalangeal joint. So the Trossius sign, Schwastek sign. How to elicit the Schwastek sign? Tap the facial nerve as it comes out of the parotid gland. Okay, you know, near the temporomandibular joint. Okay, so the facial nerve comes there. You tap on the facial nerve. Okay, and if there is twitching of the facial muscles, it indicates that it is a there is hypocalcemia. Okay, so these are some of the clinical signs, okay, so by which we record the hypocalcemia. Okay, so hypocalcemia can be detected by these three signs. Okay, now as I said earlier, in this person, okay, so the post thyroidectomy, so the person is having low parathyroid, the hormone levels, because the parathyroids were removed accidentally. Okay, now suppose if I want to save the parathyroid gland, okay, how does the surgeon save the parathyroid gland? How does he save it? So here you can see the parathyroid glands, the superior parathyroid glands are usually more constant in position. Okay, the inferior, you already know that it is a very tiny structure which we cannot see. Okay, so the superior parathyroid gland, okay, it's more constant in position. Where it is located, you know, this is the superior thyroid artery. Trace the superior thyroid artery near the end part of the superior thyroid artery. So there will be superior parathyroid gland. Okay, so leave a small amount of thyroid tissue around the posterior border at the end of the superior thyroid artery. Okay, so that will save the some amount of parathormone. Okay, so that will save some amount of parathormone. But suppose if the parathyroid glands are removed, okay, totally removed, okay, then you can give drugs like parathormone as a drug substitutes or injections. Okay, so that's it regarding the parathyroid glands, how to preserve the parathyroid glands during the thyroid surgery. Okay, so you need to trace the superior thyroid artery until its termination into the thyroid gland. Okay, and then locate the uh, parathyroid, superior parathyroid gland. Okay, so sometimes it might not be even visible to the naked eye. Okay, but try your level best to find out the where is the location of the superior parathyroid and save a moment of some amount of tissue in it. Okay, so that's it regarding the parathyroid glands. Any doubts? All right, the last is the pancreas. Okay, the pancreas, it's already dealt, okay, with the in the gastrointestinal module. So only the few specific points with regard to the endocrine aspects I will be discussing here. The pancreas is both an exocrine and an endocrine. That is, it has got both duct and a ductless structure. Okay, the exocrine parts, they are darkly stained because of the serous acini. There is no myoepithelial cells, but pancreatic stellae cells are present. Okay, so there will be presence of centroacinar cells. Okay, the centroacinar cell, which is a characteristic feature seen in pancreas. Okay, and lastly, there will be the presence of ducts, intercalated, intralobular, interlobular, and the main pancreatic duct. So these are the exocrine pancreas, which was discussed earlier. Now the endocrine pancreas. The endocrine pancreas, they do not have any ducts. That's why it's called as endocrine. They release the hormones directly into the bloodstream. So these are called as islets of Langerhans. Okay, so they are called as islets of Langerhans. Okay, and they are located amongst the serous acini. Okay, but they are lightly stained. Okay, they are lightly stained. Okay, the islets of Langerhans, they are more located on the tail of the pancreas, and there are approximately 1 to 2 million islets of pancreas in every human being. Okay, so this is the picture of the pancreas, the histology of the pancreas. So here you can see the darkly stained exocrine part of the pancreas, which secrete the pancreatic enzymes, and in between you are able to see the lightly stained structure. Okay, lightly stained structure. So this is called as islets of Langerhans. Okay, now what is present in the islets of Langerhans? So this is the islets of Langerhans under high power. Okay, you can see that it is lightly stained, and excuse me, and this shows the presence of centroacinar cells. Okay, so this shows the location of the centroacinar cells. Now let's see what are the cells which are present here. There are in the islets of Langerhans alone. I'm not going into the exocrine pancreas because that's discussed in GIT. The endocrine pancreas, so the alpha cells, beta cells, delta cells, and F cells are also called as PP cells. Okay, the alpha cells secrete glucagon, beta cells secrete insulin, the delta secrete somatostatin, and the F cells are pancreatic polypeptides. They secrete pancreatic polypeptides. Okay. So that's it regarding the pancreas. I'm not going into the details of the development of pancreas, which was already discussed in the foregut. If you could remember, there is a dorsal pancreatic bud and a ventral pancreatic bud. Then there is a rotation of the pancreatic buds along with the stomach. Okay, and the ventral pancreatic duct lies below the dorsal pancreatic duct. Okay, so they lie below the dorsal pancreatic duct. Okay, and we are saying the other clinical abnormalities, the annular pancreas, which resembles like pyloric stenosis, but the only difference is the patient is able to cope up a little bit. Okay, he or she will be able to cope up. Sorry. The annular pancreas. Sorry, where was I? Okay, the annular pancreas, because of the obstruction, so it will be bile stained. Okay, in case of annular pancreas, whereas in case of pyloric stenosis, so it will be non-bile stained. Okay, projectile vomiting. Both of them will be having projectile vomiting. Okay, so this is regarding the three aspects. Okay, so the adrenal gland, parathyroid gland, and the pancreas. Do you have any doubts?